Welcome to another Clinical Conversations GE Healthcare webinar series, Structural Heart Disease and Treatment, presented by Alicia Monroe, Clinical Education Program Leader for Vascular. Before we begin, let's review some housekeeping items for the best webinar experience. Webinar performance recommendations and widget information. For the best viewing experience, we recommend using a wired connection and closing any programs or browser sessions running in the background. Webinars are bandwidth intensive, so closing any unnecessary browsers or tabs will help conserve your bandwidth. For the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up. Also, make sure your media player and Adobe Player are up to date. Some networks cause slides to advance more slowly than others. If your slides are behind, push F5 on your keyboard and it will refresh the page. At the bottom of your screen, there are multiple application widgets you can use. Your icons may look a little bit different than the ones displayed here. All widgets are sizable and movable, so feel free to move them around to get the most of your desktop space. Hover over the widget to see its function. There will be a short period of time available after the presentation for questions. If any come to mind during a segment of the presentation, please submit the question using the Q&A widget, and they will be answered as time permits. If we do run out of time, we will answer them later via email. After the question and answer period is over, you'll have 10 minutes to take the assessment quiz. The CE widget will be active once you have completed 50 minutes of viewing time. If you arrived late, your CEU may not be accessible if the time requirement is not met. You can access the quiz using the pencil widget found on your screen. You'll need to answer 8 out of 10 questions correctly to earn 1 CE credit. Upon completion of the test, you'll be able to print out your CE certificate by clicking the yellow certificate icon. Once again, participation time must be met for the CE widget to be activated. If you are not able to attend the full 50 minutes time period, the webinar will be recorded and available on demand. You'll receive an email with a link to access the on-demand session when it's available. You'll have access to the test and the CE certificate there as well. Be sure to check out the resource list of PDFs that you may find useful for your imaging needs or department. And last, we would appreciate your feedback. Let us know what you think of the webinar and future topics you might like to see covered. The survey is the dark green icon.
Thank you, Summer, for that introduction. I really appreciate it. Once again, welcome everybody. My name is Alicia Monroe. I am a registered radiologic technologist with my vascular interventional credentials. Prior to my career with GE, I was an interventional vascular technologist in cardiac, neuro, vascular, and special procedures labs for roughly 10 years. I joined GE Healthcare as an application specialist, and I traveled the nation training and supporting customers on everything from our IGS-5 to our IGS-7 discovery systems, as well as advanced applications. Now I continue to educate as a clinical education program leader for vascular. I get to support customers remotely through telepresence within the GE Cares community and creating webinars just like this one. Please check out the resources widget to visit the GE Cares website, where you can find webinars, videos, quick reference guides, and other great resources for your team. It's free, and you just need your system ID and email to get started today. Please pause for a few moments to read and review the disclaimer slide. This webinar is intended for educational purposes only. Let's get started and take a look at today's learning objectives and agenda. The purpose of this webinar is to provide an overview of structural heart disease and treatment. The intended audience for this webinar is for radiology techs, nurses, and interventional staff looking for an overview of all things structural heart. Upon completion of this webinar, you will be able to understand heart anatomy, define structural heart disease, identify various treatments, and describe the heart team and the procedural room. So let's review the learning agenda. We will start with anatomy overview and move into structural heart disease. From there, we'll discuss common structural heart treatments, and we'll look at the heart team and the procedural room. And lastly, we'll review new technology aiding in these complex procedures. We can't dive into structural heart disease without first discussing the structure of the heart. In this section, we will learn about anatomy of the heart and its functionality. So let's kick things off with some fun and interesting facts. Did you know the heart is a muscular organ about the size of the fist? It's located just behind and slightly left of the breastbone. The heart pumps blood through the network of arteries and veins called the cardiovascular system. The blood will beat about 115,000 times each day and pump about 2,000 gallons of blood. The drumming sound of a heart beating is caused by the opening and closing of its valves. It's a rhythmic series of events that cause this muscular organ to contract and then relax. As the heart contracts, it pushes blood through the body via the circulatory system. It fills with blood on its relaxation, preparing to execute the same cycle over and over. Lastly, what may be my favorite fact is that laughter is good for the heart. It relieves stress and aids in boosting the immune system. And if laughter is good for the heart, think of the effects of stress. What can you do today to guard your heart from stress? To understand structural heart disease and treatment, we have to spend some time to first understand how the heart is supposed to function, why the heart beats, how blood flows through the heart, and how it's regulated. Those are all questions that need answered before we look at the disease process and treatment. When you are learning of blood flow in the heart, think of the route that can lead to certain chambers. When you think of various functions of the heart anatomy, think about its impact on the heart, the lungs, the brain, and the body. If the heart cannot function at its full capacity, our bodies cannot function fully. The heart has 4 chambers. The right atrium receives blood from the veins and pumps it to the right ventricle. The right ventricle receives blood from the right atrium and pumps it to the lungs, where it is loaded with oxygen. The left atrium receives oxygenated blood from the lungs and pumps it to the left ventricle. And the left ventricle pumps oxygen-rich blood to the rest of the body. The left ventricle is the strongest chamber in the heart. Its contractions create our blood pressure. The heart can be considered as 2 pumps that push blood through 2 different circuits. Diving deeper into the 4 chambers, the right atrium receives venous blood from the head, chest, and arms via the large vein called the superior vena cava, or SVC, and receives blood from the abdomen, pelvic region, and legs via the inferior vena cava, or IVC. An interesting fact is that the oxygen saturations pulled from the SVC tend to be less oxygenated than saturations pulled from the IVC. This is because your brain uses more oxygen. From the right atrium, the blood flows through the tricuspid valve to the right ventricle, which sends it to the pulmonary artery and then out into the lungs. There, venous blood is mixed with inhaled air, picks up oxygen, and loses carbon dioxide. and the oxygenated blood is returned to the left atrium through the pulmonary veins, and the whole cycle repeats itself again and again. Valves play a key role here, allowing blood to flow in one direction and help maintain the pressure required to pump the blood. Normal heart anatomy and physiology need the atria and ventricles to work rhythmically, contracting and relaxing to pump blood out of the heart and then to let the chambers refill. When the blood leaves each chamber of the heart, it passes through a valve that is designed to prevent the backflow of blood. And within the heart, there are 4 valves. The mitral valve, which is located between the left atrium and the left ventricle. The tricuspid valve, between the right atrium and right ventricle. The aortic valve, located between the left ventricle and aorta. And the pulmonary or pulmonic valve, between the right ventricle and pulmonary artery. Remember, the heart valves work the same way as one-way valves in the plumbing of your home. Each valve has a set of flaps called leaflets or cusps. The mitral valve has 2 leaflets, while all the others have 3. The leaflets are attached to and supported by a ring of tough fibrous tissue called the annulus. And the annulus helps to maintain the appropriate shape of the valve. The leaflets of the mitral and tricuspid valves are also supported by tough fibrous strings called chordae tenonnae. These can be compared to the strings supporting a parachute. They extend from the valve leaflets to small muscles called papillary muscles, which are part of the inside walls of the ventricles. Let's summarize the flow of the right side of the heart. As previously discussed, blood enters the heart through 2 large veins, the inferior and superior vena cava, emptying oxygen-poor blood from the body into the right atrium of the heart. As the atrium contracts, that blood flows from your right atrium into your right ventricle through the open tricuspid valve. When the ventricle is full, the tricuspid valve will shut. This prevents blood from flowing backward into the atria while the ventricle contracts. Then the ventricle contracts, causing blood to leave the heart through the pulmonary valve, into the pulmonary artery, and into the lungs, where it is oxygenated. Oxygen-poor blood goes through the pulmonary artery to the lungs, where CO2 is exchanged for O2, also known as the CO2 switcheroo. Just kidding. I just wanted to make sure you all were still following. The left side of the heart is also performing at the same time as the right. The pulmonary vein empties the oxygen-rich blood from the lungs into the left atrium of the heart. As the atrium contracts, that blood flows from the left atrium into the left ventricle through the open mitral valve. Again, when the ventricle is full, the mitral valve shuts, and this prevents the blood from flowing backwards into the atrium while the ventricle contracts. The oxygen-enriched blood leaves the heart through the aortic valve to the aorta, and then to the arteries and eventually into your veins to complete the blood circulation in your body. Though we aren't diving deep into the electrical activity that sets this sequence into motion, the world of cardiac intervention is just as significant as structural heart disease treatment. The coronary arteries are very important as well. Without proper blood supply, the heart muscle can die, causing the heart not to pump properly or even sudden death. The coronary arteries run along the surface of the heart and provide oxygen-rich blood to the heart muscle. A web of nerve tissue also runs through the heart, conducting the complex signals that regulate contraction and relaxation. Now that we've had a heart anatomy overview, let's look at different types of structural heart diseases. You hear it all the time. Eat healthy, exercise, reduce stress, get adequate sleep. When you check these items off daily, you're taking important preventative action towards the formation of coronary artery disease, or CAD for short. And it's caused by a plaque buildup in the arteries that can cause chest pain and potential heart attacks. Again, a heart attack will affect the heart muscle and the squeezing function of the heart. And structural heart disease is a different problem. Structural heart disease is a term used to describe defects or disorders in the heart structure. It's valves, for example. A heart problem that is structural could be congenital, meaning it was present at birth, or it can result from aging or underlying diseases, causing wear and tear on the heart later in life. The symptoms of structural heart disease vary depending on the condition and the patient. Most of the time, the symptoms of heart disease could include mini strokes, also known as transient ischemic attack, or TIA, stroke, shortness of breath, chest pain, a tight feeling in the chest, high blood pressure, leg cramps, kidney dysfunction, irregular heartbeats, extreme fatigue, and coronary artery disease. So how is structural heart disease diagnosed? In this section, we'll review various testing that is involved in determining whether a patient has structural heart disease and what type. After seeing a patient in their office or the hospital and discussing symptoms, a cardiologist will send the patient for further testing. The types of testing physicians may order are an electrocardiogram, or ECG for short. An ECG records the electrical signals and can help your doctor detect irregularities in your heart's rhythm and structure. You may have an ECG while you're at rest, or you may have a stress electrocardiogram. An ECG would be performed while you exercise. Polter monitoring is another type of testing. A Holter monitor is a portable device you wear and can record a continuous ECG. You usually have it on for 24 to 72 hours. Holter monitoring is used to detect heart rhythm irregularities that aren't found during a regular ECG exam. Or you may have an echocardiogram. That's another non-invasive test which includes an ultrasound of your chest and shows detailed images of your heart structure and its function. Further testing to diagnose structural heart disease can include a stress test. This type of test involves in raising your heart rate with exercise or medicine while performing heart tests and imaging to check how your heart responds to the physical activity. It may involve a procedure called a cardiac cath. In this test, a sheath or short tube is inserted into a vein or artery in your leg and now can be done even in your arm. That hollow, flexible, and longer tube, called a catheter, is then inserted into the sheath. Under live X-ray guidance or fluoroimaging, your doctor threads the catheter through that artery until it reaches your heart. The pressures in your heart chambers can be measured and contrast dye can be injected. The dye can be seen on an X-ray, which helps your doctor see the blood flow through your heart, blood vessels, and valves to check for abnormalities. Cardiac computerized tomography, or a CT scan, is often used to check for heart problems. In a cardiac CT, you lie on a table inside a donut-shaped machine. The X-ray tube inside the machine rotates around your body and collects images of your heart and chest. This procedure may be performed with or without dye. A cardiac MRI is also a test that may be ordered. And for this test, you will lie on a table inside a long tube-like machine that produces a magnetic field. The magnetic field produces pictures to help your doctor evaluate your heart. Diagnosing structural heart disease isn't as easy as you think. Sometimes an initial heart murmur may lead to an electrocardiogram and then further imaging. The testing can span over several modalities to pinpoint the exact issue. In some instances, the patient may already be in the process of having a cardiac cath for chest pain that leads to the discovery of structural heart disease. Either way, it takes a skilled hospital team to utilize the latest software and communicate the findings to the cardiologist. In this section, we'll review some of the most common structural heart procedures. Advanced imaging technology now allows doctors to diagnose structural heart problems earlier in patients' lives. Even before birth, structural heart defects can be diagnosed. Many of these babies have surgery to fix congenital heart defects in the first days or years of their lives. New device technology allows for highly compressed stents, valves, and other tools to be run up straw-sized catheters and into the heart with a small incision. This amazing combination of advancements in tools, devices, and imaging, paired with highly skilled interventionalists, are why minimally invasive structural heart procedures are rapidly evolving. Structural heart disease is one of the most exciting and fastest growing fields in cardiovascular medicine today. For many patients with structural heart disease, previously high-risk or open heart surgeries have been replaced by non-surgical, minimally invasive procedures with often lower risk, less trauma, and a faster recovery time. Such procedures include heart valve repair and replacement that can be performed through catheters. Originally designed for high-risk populations, structural heart procedures are being performed on lower and lower risk populations. When physicians are deciding whether surgical or catheter-based treatment is an option, they will look at several factors. Structural heart specialists and cardiac surgeons work hand in hand to provide the widest range of options for patients with structural heart disease. In some cases, open heart surgery is a better option, and in some, catheter-based structural heart procedures are better options. The team will often weigh several questions, like, what will provide the best result? What's an acceptable degree of risk with the procedure? How long will the result last from each treatment? What can the patient tolerate? And lastly, what does the patient want? Very similar to cardiac catheterization labs, structural heart disease procedures are performed through catheters as well. A variety of instruments are passed up through the heart and used to deliver treatment devices. And these devices are typically placed through catheters in the leg. For example, in patients with diseased heart valves, a new valve is passed through a catheter and secured into place. This incredible device technology allows these valves to be passed up to the heart in a highly compressed state, so it can pass through a catheter, and then when in the correct position, it can be expanded appropriately to the desired size, where it becomes a new, fully functioning valve. Risk factors for catheter-based procedures include bleeding, blood vessel complications, problems with the replacement valve, such as the valve slipping out of place or leaking, stroke, heart rhythm problems, and possible pacemaker implantation to relieve those problems, kidney disease, heart attack, infection, and death. Of course, advancements are being made every day to improve patient outcomes in the structural heart world. There are devices approved in Europe that are not yet approved in the United States, and that just goes to show you that every day new technology is being developed to help improve patient outcomes with minimally invasive procedures. Structural heart procedures can be separated into three categories: valvular, congenital, and structural. And while this looks like a very long list, we'll detail these procedures in the slides ahead. Atrial septal defects are holes in between the top chambers of the heart, or also known as ASD. And ventricular septal defects, or VSD, are holes in between the bottom chambers of the heart. The majority of these defects are present from birth and, if large enough, can lead to heart enlargement and heart failure. Most of these defects can be closed with catheter-based devices that cover the defect. ASD and Bsd closures tend to have excellent results in appropriately selected patients. In an ASD or VSD closure, which are typically performed on pediatric patients, a closure device is inserted in the vein and sent up to close the opening in the septal wall. Prior to the procedure, a TEE is performed under anesthesia to confirm the patient's defect can be closed with the device. The patient is then transferred to the procedure table, where the physician will again measure the opening using a balloon-tipped catheter. The appropriate size is very important for the success of the procedure, as an undersized device can lead to the plug free floating in the heart. These patients often go home same day with little recovery time, as the procedure usually takes 1 to 2 hours. What may be the most significant advancement in the structural heart disease in the last decade has been the transcatheter aortic valve replacement, or TAVR for short. In this procedure, a new aortic valve is placed inside the old diseased aortic valve, or failed surgical valve. Most commonly, the catheter is placed through an artery in the leg, and the valve is passed up to the heart. And once deployed, it begins functioning immediately. The catheter is then removed, and the incision in the groin, neck, or chest, depending on the route chosen, is closed. Again, the recovery is relatively short, with most patients heading home same day or with a one-day stay. The TAVR procedure is currently the most common structural heart procedure in the world. A common theme with catheter-based structural heart procedures is proper sizing. Inadequate sizing and malposition can cause valvular leaks and drastically reduce procedural success. There are different types of valvular leaks: central, between the leaflet; paravalvular, between the prosthesis and the deployment zone; or suprascrotal, a form of PVL, or paravalvular. Clinical studies have shown that even mild regurgitation can be associated with an increased post-TAVR mortality rate. Advancements in software have greatly improved TAVR success by decreasing instances of malposition and post-procedural complications. Some of the most common complications that plague TAVR devices include malpositioning, crimp-induced leaflet damage, paravalvular leaks, thrombosis, conduction abnormalities, and prosthesis patient mismatch, or PPM. These complications are currently difficult to predict prior to the procedure. There are patient-specific risk factors that are thought to include the calcification landscape of the native valve, properties of the aortic root, and the conditions such as hypertension, coronary artery disease, heart failure, and bleeding. This image shows the importance of adequate imaging during a TAVR procedure. In the next short clip, you'll be able to see how the advancements in software can aid in the procedural planning and successful device deployment. The pre-procedural CT is used to form a dynamic roadmap during the TAVR procedure. With this technology, previous CT imaging is fused and registered to the patient on the table. As the imaging changes, the 3D overlay will accommodate, lowering procedural dose, contrast, and case time, and improving overall procedural outcome. I swear watching that video never gets old to me. I love seeing the fusion of CT and real-time fluoro imaging. So transcatheter mitral valve repair. It's a procedure for patients with a leaky mitral valve known as mitral regurgitation. This procedure is performed once again using catheters and devices placed through the leg. A clip is placed on the leaky portion of the valve to reduce the amount of leak. It's an attempt to replicate an old surgical technique where the stitch was placed between the leaking portions of the valve. The most common transcatheter mitral valve procedure currently performed in the United States for structural heart disease is called the MitraClip. There is currently exciting development and trial procedures that are underway for transcatheter mitral valve replacement, allowing an entirely new valve to be placed in the mitral position. There are current challenges with the transcatheter mitral valve replacement when compared to its counterpart, transcatheter aortic valve replacement. For instance, access in TAVRs is most commonly transfemoral, where the catheter-based mitral valve replacement may require transfemoral with transseptal puncture or transapical approach. There are two types of mitral regurgitation. Degenerative MR, also called primary MR, is caused by damage to the mitral valve apparatus with prolapse or flail of the leaflets. It can be related to age, a birth defect, or an underlying heart disease. Functional MR is also called secondary MR, and it is caused by the enlargement of the heart due to heart attack or heart failure. Transcatheter mitral valve repair procedure only involves a small puncture in the femoral vein rather than open heart surgery and the need to stop the heart. The delivery catheter is pushed up into the heart and a transseptal puncture is made into the atrial wall. The catheter is then advanced from the right into the left atrium and is bent 90 degrees to access the mitral valve and to attach the clip to the native valve leaflets. The procedure is performed under transesophageal echocardiography in a Cath lab, or sometimes a hybrid OR. The ultrasound imaging allows real-time assessment of the device and valve leaflet positioning and shows when the leaflets are fully engaged by the device for final deployment. The Doppler ultrasound is used to show blood flow and to identify the location of regurgent jet and any residual jet after the device has been implanted. Additional clips may be required to resolve any residual MR seen in the TEE. This complex procedure relies heavily on imaging for success. Atrial fibrillation patients are at an increased risk of stroke because of clots that can form inside a structure in the top chamber of the heart, known as a left atrial appendage. The use of blood thinners can reduce the risk of stroke, though many patients cannot take blood thinning medications due to a high risk of bleeding. In some patients, a catheter-based structural heart procedure known as a left atrial appendage occlusion can be performed to eliminate the appendage. One of the most common examples known today is the Watchman device. This device is deployed inside the appendage and works like a plug, preventing blood from entering the pocket. Imaging is key in structural heart procedures as it enhances the operator's ability to navigate patient-specific anatomy. A left atrial appendage occlusion requires transseptal puncture. In addition to high operator skill, the image guidance aids in this process. Echo imaging is used for sizing and during the procedure, as well as fluoroscopy to determine the best angulation for the device deployment. Pre-procedural CT planning for the procedure is becoming frequently used, especially with the advancement of 3D software. The left atrial appendage anatomy and orientation can be very complex and differs in every patient, as you see above. This image details the most common types of atrial appendage variances. one of the coolest advancements in structural heart can be seen within imaging and software. In this example, GE Healthcare's Valve Assist AW software is used to take the preoperative CT and utilize it intra-procedure as a dynamic 3D roadmap during a left atrial appendage closure. The 3D CT overlay is registered to the patient and fused with fluoroimaging, thus eliminating the need to update as the tube is angled, as the table moves, etc. It's used to guide each step with confidence, from the Transseptal Puncture to the device deployment. These advancements significantly reduce contrast, procedural time, and dose. As you can see, the model has reconstructed the left atrial side of the heart, again, reducing the need to fill with contrast. And it also can be used to mark off certain areas or measure as well. That short little 6-second video clip displayed advanced features so beautifully. Another procedure that is considered structural heart care is the hypertrophic cardiomyopathy procedure. HOCM for short is an enlargement of the heart that causes the obstruction to blood flowing out of the heart. This is actually a relatively common structural heart disease and is seen in many Cath labs around the country. In patients that remain with symptoms despite medicines, there are two options. First is an operation known as myomectomy, which is an open heart operation that involves cutting out the area of tissue causing the obstruction. But the less invasive approach is known as an alcohol septal ablation. It is a catheter-based procedure that involves injecting a small amount of alcohol into the area causing the obstruction, which then will cause it to shrink later. Possible complications can affect the heart's electrical system, causing heart block, which requires the implantation of a pacemaker. The patent ductus arteriosus, or the PDA for short, is a connection between the main blood vessels that leave the heart. The PDA connects the aorta and the pulmonary artery so that before birth, when the baby is not breathing air, oxygen-rich blood from the mother is able to reach the baby's body. In about 2 out of every 2,000 births, the PDA stays open, which can lead to heart enlargement if it stays that way into adulthood. In most patients, the PDA can be closed by a transcatheter technique. A catheter is guided through the femoral vein under fluoro guidance. An occlusion device, much like a plug, is then inserted into the catheter once it reaches the PDA. The plug is made of nitinol wires that allow it to return to its shape after passing through the delivery catheter. Once in place, this device will block the vessel and stop blood from flowing into the lungs. Other structural heart procedures that we didn't go too far into detail with are the repair of coarctation of the aorta, repair of various aneurysms, repair of fistulas, balloon valvoplasty for mitral stenosis, transcatheter mitral valve replacement, transcatheter pulmonary valve replacement, insertion of mechanical circulatory support, intracardiac biopsies, intracardiac ultrasounds, pulmonary emboli removal, and paravalvular repair. In today's world, with an ever-aging population, the ability to extend and enhance lives has also grown. Advancements in TAVR and other structural heart therapies like left atrial appendage closure and transcatheter mitral valve repair and replacement are absolutely life-changing. More than 5 million Americans are diagnosed with heart valve disease each year. Yet many patients go untreated or undertreated partly due to the lack of available and appropriate care. More hospitals are working to answer that call, with cardiac programs that treat more than cardiovascular disease, but also structural heart disease. What are the components of a structural heart team? In this section, we will take a look at the team and the structural heart procedural room. The structural heart procedure room is a very busy place. These procedures require a great deal of expertise and a team approach. The heart team generally consists of interventional cardiologists, heart surgeons, scrub techs, nurses, and imaging specialists. And each member has a key role, and ultimately, the combination of these specialists allows for the development of optimal treatment plans. In many structural heart procedures, the interventional cardiologist and the surgeon will perform the procedure while imaging specialist guides them. The heart team will generally consist of an interventional cardiologist to perform the procedure, and in most cases includes a heart surgeon, as well as radiology technologists to assist with setup and scrubbing the case, a TEE imaging specialist for guidance, anesthesia in most cases, a nurse and circulator to help with the procedural care, device representative to help with device questions from the team, monitor personnel to document and follow hemodynamics. Collaboration is a key to a smooth running program for optimal patient care and outcomes. It is critical to pair a competent and passionate surgeon and an interventional cardiologist and match them with a highly skilled multidisciplinary team. There are several intra-procedural imaging needs during structural heart procedures. Fluoroscopic guidance is an absolute must. It is needed from the initial start of the procedure all the way until device deployment. Ultrasound is used in most cases for access. TEE, or transesophageal echo, is used for majority of the procedure as well. And a planning CT prior, which has become more and more trendy, especially with the advancements in software to be utilized during the procedure as well. From access to deployment, imaging is utilized to verify proper placement of devices and procedural success. A skilled team runs like a well-oiled machine. Education brings the team together. When the team understands the procedure, the what, the why, the how, they are more confident in themselves and those around them. Practice. Perform mock cases, work with device reps for specific trainings, etc. Communication is key. When a team trusts each other, they will speak up, and mistakes are avoided because each member of the team is empowered to make a difference. Post-case feedback and debrief is welcomed. Structural heart programs start with a skilled interventionalist or surgeon, but are entirely more successful with a cohesive team. With a large procedural team like the heart team, imaging, and support staff, it is key that everyone knows their role and their value. In the last several years, there has been an explosion of structural heart disease interest, driven largely by the adoption of transcatheter aortic valve replacements, mitral valve interventions, and transcatheter left atrial appendage closures. Historically, pediatric interventional cardiologists have been the most involved in structural heart procedures because they primarily treat congenital anomalies. More recently, the field of adult structural heart disease has blossomed, and it includes many structural heart disease conditions that are not diagnosed or acquired until the adult years. A successful structural heart program requires a multidisciplinary heart team and institutional support, as well as specific structural experience requirements for the interventional cardiologist. For TAVR, the Centers for Medicare and Medicaid National Coverage decision requires that the interventional cardiologist have, quote, professional experience with 100 structural heart disease procedures in a lifetime, or 30 left-sided structural procedures per year, of which 60% should be balloon aortic valvuloplasty. ASD and PFO closures are not considered left-sided procedures, end quote. When facilities are looking to build a successful structural heart program, the setup will often evolve into a hybrid OR suite. A hybrid operating room is an advanced procedural space that combines traditional operating room with an image-guided interventional suite. Specific days could be dedicated for structural heart procedures, and other procedures, such as Cath and peripheral, could be performed in the same room to utilize the technology on the off days. GE Healthcare's Discovery system offers a unique component to your hybrid OR needs. The Discovery offers a wide bore and large detector that enables steep angulations for cardiac cath and PCI procedures, as well as peripheral procedures. Wide access at the patient head for an anesthesiologist and sonographer to move freely, and ample space for the heart team with their respective equipment. The Discovery also offers 2 parking positions for the system to move away from the table. More space for setup, more options for room usage, and customizable room configurations. In addition to the incredibly versatile and accommodating Discovery system, GE also offers advanced software to help verify placement and improve patient outcomes by reducing contrast, procedural time, and patient dose. ValveAssist offers simplified planning, zero-click aorta segmentation, simple measurement tools, increased flexibility, the ability to support and import DICOM data from other planning software tools. Calcification enhancement improves the visualization of moving contrasted structures. Pre-op CT planning fused with X-ray helps visualize device position within an anatomical environment when no anatomical landmarks are available. All right. Thank you guys so much for joining today's Structural Heart Disease and Treatment webinar. I really appreciate it. I'll now take a few moments to answer some of your questions. Remember, if we run out of time today, I'll return them via email. So don't be discouraged if you have some questions that come up. Even after the Q&A portion is over, just be sure to go ahead and push those through, and I'll return them later on if we run out of time. Please, please, please feel free to provide feedback. Any topics that you'd like to see in the future, we would love to know about so that we can create them for you and your team. It gives us great joy, especially when we know we're talking about something that you all are very interested in. Okay, so I'll begin so you guys can get on to taking your tips. The first question comes from Jesse. Can you talk more about Transseptal Approach? Our team is just starting out. Okay. I think this means you're just starting out in the structural heart world. I totally understand that. Came from a Cath lab as well and did not do structural heart initially. So the whole structural heart thing was sort of mind-blowing to me. And one of those things that I was exposed to a little bit within EP is a transseptal approach. So a transseptal puncture is used anytime that you have left atrial access. So think of procedures that you have to get to the left atrium for, like transcatheter mitral valve repair, a left atrial appendage closure. All of those procedures require a septal crossover. So initially, there's a puncture in the femoral vein of the leg, and the catheter would be sent up via the IVC. Then, of course, it gets to the right side of the heart, and it needs to cross over into the left atrium. The TEE is utilized, so transesophageal echo is needed to improve the safety and success of the transseptal puncture. It's almost always used. In fact, I've never seen it not be used during transseptal punctures. And more recently, a device, a special needle, I should say, that's come out, radiofrequency needles have been overutilized, and they're coming, people are using them more and more often because they give off a radio frequency, and that position is confirmed via TEE. So huge advantage there, and as far as the safety of a transseptal puncture is concerned. And then depending on the actual puncture site, so if it's in the central location of the septal wall, that all depends on what's happening when they cross over to the left atrium. So how much room is needed to torque and maneuver. So that depends on how central the puncture site is. And then after the puncture, the needle will be removed from the catheter, and then the procedure will take place. So, devices and valves and that sort of thing are passed through the catheter. And then afterwards, everything is removed. And typically, the puncture will heal on its own. So it's a great question. It's also to be known that there is transapical approaches that I kind of talked about a little bit during this webinar, but a transapical approach is actually a puncture of the apex. So access is established through, I think, the 5th and 6th rib in that space. And an incision is placed, and then the apex is punctured, and that is sort of an antegrade access into the left atrium. It's very stable. It is very straightforward and is easy to use. However, a transapical approach is sort of not as used just because of discomfort post-procedural and, of course, the risk of bleeding. So that's something to consider, especially in patients that have vasculature issues and access issues. But you'll see, especially during when we talked about the circulatory system and the flow of the heart, there are lots of routes that kind of lead back to certain places, but they're not always utilized because of complications and the lack of torqueability with catheters and things. So great question. Thank you for asking. Okay. It looks like a lot of these questions from here on out are about how to print your certificate. That is in your certificate widget. You guys have taken the test super fast, but just print it out from clicking on the certificate widget or write down your information so you can enter it in when it comes time to renew your license. Thanks so much. I'll stop here so you guys can take your exam in peace. Thanks again for your participation in this course. This concludes the structural heart disease and treatment. The console will stay open for the next 10 minutes so that you can complete the assessment in order to earn your CE credit. This CE activity may be available in multiple formats or from different CE sponsors. The ARRT does not allow CE activities to be repeated for CE credit in the same biennium.